Hi, I'm Dr. Bob Dannenhoffer, the Public Health Officer for Douglas County here in Oregon. It's a beautiful Friday afternoon here in Oregon, so if people are outside enjoying the sunshine, I certainly don't blame you. Anyway, so we're here today to answer your questions, and some people put in some very good questions on the Facebook questions at douglaspublichealthnetwork.org, so we have an email box just for your questions. Facebook questions at douglaspublichealthnetwork.org. We guarantee that if you get it into us before the day of the show, we're able to research that and get back to you on those. But you can also put the questions in the chat section and we'll get to them there. So lots happening in the world. You would think 15 months into it, things would be slowing down. But when I look at what I do on a daily basis, it hasn't slowed down very much. So let me tell you what we're at. So in the world, still a very active pandemic. You know, there was a first small peak, a second small peak, third bigger peak, and now this is the biggest fourth peak, and it certainly is coming down, and that's a good thing. But still, in the world, we've had 172 million cases, and likely many more than that because some weren't diagnosed, and 3.7 million deaths. So that's really a lot of deaths. When you consider the death toll from worldwide accidents, from wars and whatever, 3.7 is a big number. Now, it's a big world, but still 3.7 million deaths is very significant. When we look in the world, it's funny where the disease is hot. So it's hot in Mongolia. So I don't think much about Mongolia, but Mongolia, a country squeezed in there between China and Russia, has really been struggling with COVID for several weeks now, with very high levels, but they also have really high vaccination levels. So it's a bit concerning and confusing. India and Nepal are especially struggling. So Nepal really relies mostly on tourism, and they're really struggling. Apparently there were a bunch of cases brought in by climbers who camped in Nepal to climb Everest. And apparently there's a lot of spread there in Nepal. India is just really very troublesome. I talked to a friend the other day whose husband is from India, and they've gone back to India to do mission trips. And she was talking about the really dire situations where a young person, somebody in their 40s that they knew, who got COVID, got sick, called the ambulance ran out of oxygen, and they died on the way to the hospital. So these kinds of stories, which we don't hear about much in the U.S., really are happening in the rest of the world. As you know, for the last 8 weeks, we've been saying, well, my big concern is if the cases in Africa start to increase. Because, again, Africa has very low rate of vaccination, a very low rate of previous disease, so there's not much natural immunity, and not a very good healthcare system. And so I've been worried about that. And this week, we started to see that jump in Africa. So in Tunisia, Libya, Botswana, Namibia, and South Africa, it's starting to heat up in those areas. So we're just going to keep watching that very carefully. And then South America continues to be an absolute mess. So Brazil, Argentina, Peru, Uruguay, Colombia, all places with lots of disease. And it's surprising because some of the countries in South America, especially Uruguay, have pretty good vaccination rates, and despite those pretty good vaccination rates, have continued to have high levels of disease. There was a report this last week from Peru saying that although they have a very high death count, the number of deaths from COVID is likely 3 times higher than that's been reported, just because of the chaos that COVID has caused. So although things are quiet in the U.S., and it really is, it's not quiet in the rest of the world. And I think we have to be careful because it doesn't take much for it to spread from one area to another. So you'll know that I've talked about Taiwan, which has really done a very nice job with this, and Australia, which has done a very nice job with it. Both have had outbreaks in the last 2 weeks related to people coming in with the Indian variant, the 617, or the Delta variant, which then caused huge outbreaks for those countries in Australia and Taiwan. So, for example, in Taiwan, it came in with a flight crew from an airplane, spread to thousands of people. This will trace back all to that one individual. So these variants we know are really quite contagious. You know, if you came in with the flu or chickenpox or something else, you might spread it to a few people, and over the space of a week or two, you'd have 30 cases or 50 cases. They had 3,000 cases related to this one individual who brought it in. So very worrisome with these new variants about how contagious they are, and really concerning because in Africa, which has not seen much of the disease, they're not going to start with those ancestral strains. They're going to start with P1, which is the gamma strain, or the 617, which is the delta strain. They're going to start off with an already a bad variant, and it could get worse from there. Well, in the United States, we're doing very well. So there are a lot of places that are having not very much disease. So my son is going back to Washington, D.C., where he lives and works for the NIH. And Washington, D.C., a big place, they only had 28 cases a day. That's about as many as we're having in Douglas County. So some places are doing great. Nebraska only had 20 cases in the whole state. So there are some places that are doing very well, and then other places that are struggling a little bit. So Nebraska's doing okay, but northern Missouri and southern Illinois are struggling a little bit. Again, there's the variants there. There are places just scattered throughout the country in Colorado they're having case in the Texas Panhandle and a little bit in West Virginia, but for the most part, the U.S. is pretty quiet. And when we talk about cases per 100,000 per day, it's sort of an easy thing to remember. We in Douglas County have usually been between about 5 and 15. We're a little higher than that now. In the U.S., we're at 4.5 cases per 100,000 per day. So let me contrast that with places that aren't doing so great. Uruguay, 99 cases, so 20 times as much disease in Uruguay as in the United States. In Mongolia, 30 cases per 100,000 per day. Argentina, 70 cases per 100,000 per day. That's a lot of cases. And then there's some small countries, the Maldives, which are these little islands off India, which has a lot of disease, and the Seychelles also have a lot of disease. Those are two areas that are islands, and typically islands have been better able to protect themselves, and they have high vaccination rates, and yet they've had a lot of disease. So although I think things are going great, and I don't want to be Debbie Downer here, but I really do want people to be aware that these variants are really the wild card here. So as I said in the beginning, for many weeks now, if the variants tend to be biologically fascinating but clinically insignificant, we're done with this. We're nearly done with this. But if it turns out, on the other hand, that the variants are really nasty, more contagious, more deadly, that is a concern. And there's a real worry about that. So Brazil, as we've talked about for many weeks, has had a bad course of this since last July. So they had a peak last July. The thought was, well, it'll just let people get immunity. We'll avoid a second phase. Well, they certainly got a second phase. The other thing that they're noting, in the first phase, there were not that many sick kids and very few childhood deaths. In this second phase, a lot of childhood deaths. So 2,000 kids in Brazil have died in this last wave there, suggesting that the P1 or the gamma variant, which is there, is more deadly for kids. And we've kind of guessed that the variants are worse for kids. So the B117 in the UK and Michigan, when they had outbreaks of the B117, they saw many more kids than they'd previously seen. And now in Brazil, the P1 seems also to be affecting kids. Well, in Douglas County, we had a terrible week. 28 cases, 31 cases, 22 cases, some of our highest numbers ever. And there's a couple of things to point out on that. So there's no one place. In the past, there were times where you could say, well, most of the cases are coming from this nursing home, or most of the cases are coming from this farm, or most of the cases are coming from this outbreak. We don't really have that. We don't have any outbreaks with more than 10 current active people. But we have a lot of little ones. And a lot of little ones are scattered all over the county. They're in businesses. They're in social gatherings. They're in school-related activities. So not necessarily classroom-related, but other school activities, sports, clubs before and after school, kids driving together before after school, kids hanging out after school, which is where we're seeing some of the spread. And then there are a lot of people who are not wanting to talk to us at this point. So these are people who are maybe denying that COVID's a thing, or they just don't want to talk to anybody that's quasi-governmental. So there's a bunch of cases now that people have not done an interview, and this is kind of new. Early on, almost everybody we could interview right now there's a bunch of people that are hard to interview, so we don't really know where they got it from, nor do we know their contacts. And since we don't know their contacts, if their contacts get sick, we'll not know who to relate it to. So it's a little bit of a worrisome time. Hospitalizations are still high. Now they came down a little bit today, but unfortunately, some of that was because people died, and some of it was that people got discharged. It was a good thing. But we're still having over 10 people in the hospital each and every day, and many of those people are young. Again, it's easier for me to look at the birth dates. Anybody before 56 is a little older. Anybody born in 56 or later is just a young pup. And when I look, there are a lot of people born in the 60s and 70s, even sometimes in the 80s, who are really sick in the hospital, in the ICU, on a ventilator. Thank God most of us have never needed to be on a ventilator or been around people on ventilators, but I will tell you, to be on a ventilator is absolutely devastating to your body. You know, typically you have to paralyze people so they can stay on the ventilator, because the ventilator is forcing air into your lungs, and for many people they can fight that, and so they tend to be either paralyzed or sedated or just heavily sedated during the time that they're on the ventilator. When you're on the ventilator, you're prone to getting infections, you're prone to getting more pneumonia, you're prone to getting urinary tract infections, you're prone to getting skin breakdown, all kinds of things that happen in the ICU. And the people in the ICU work incredibly hard to protect against those things, but the longer and longer and longer you're on a ventilator, the more and more and more likely you are to have one of those troubles. And some of these people have been ventilated for 2 or 3 weeks, which is really, really worrisome. So in the past, people said, well, you know, this is really just as these old people. I'm 45 and otherwise pretty healthy. This isn't going to get me. In this last week, it's gotten a few of you. So be really, really, really careful. And again, we want to talk about the vaccine. So we had 111 cases in the time between last Friday and this Thursday. So 111 cases. We checked the vaccine status on all of those. Out of the 111 cases, 110 were not vaccinated. Let me say that again. So 110 out of 111 were not vaccinated. 1 of 111 were vaccinated. That one person was a healthcare worker who had a very mild disease, and they got it. But again, 110 to 1. Since about 50% of the people, 50% of the eligible people in the county have gotten a vaccine, that means that the risk for being unvaccinated is incredibly high. The risk of being vaccinated is very low. Again, if we were able to have everybody who was eligible for a vaccine get a vaccine, we'd have 2 or 3 cases a day, not 20 or 30. So it's a little worrisome there. But the way to fix that is to get vaccinated. We're having a vaccine event tomorrow at the fairgrounds, 9 a.m. to 2 p.m. We're going to try and make it a little festive here. We're giving both the Pfizer vaccine and the J&J vaccine. So if you want the J&J vaccine, we're going to have it. If you want the Pfizer vaccine, we're going to have it. It's your choice. We're going to have the Shave Ice truck there. So people get a Shave Ice where somebody's supporting that for us. We're going to have places for people to do selfies and whatever. So hopefully a lot of people will come. So if you know somebody who's kind of on the edge, I'm not sure I should get this or not, now's the time. Oregon is doing these lotteries. They're great. $1 million for older people, college scholarships for younger people. That's great. Now, I'm not sure that those kind of things would make me want to get a vaccine. I mean, I think I would either want to get it or not get it, and the incentive doesn't make that big a difference. So for those who have attended this on a regular basis, you know I give blood on a very regular basis. And the Red Cross is always doing these things to incentivize you to give blood, like, you know, give a pint, get a pint of beer, or give blood and get a T-shirt or whatever. Now, I never turn down the beer or the T-shirt, but that's not really the reason I donate, right? If they made it 5 T-shirts, it's not like I would donate 5 times as often, or if they stopped doing it, I wouldn't stop. But what happens on the incentives is maybe if you're on the fence, like, I'm not sure I want to donate this week, and there was an incentive for something you want to do, it might get you off the fence. So, again, I don't think these lotteries are going to be the be-all and end-all, but what's the be-all and end-all is don't be sick, right? Because people who get the vaccine aren't getting sick. So 1 out of 111 cases was in somebody who was vaccinated, and since about 50% of the eligible people have at least gotten 1 dose of vaccine, that is incredible. If it was 80% effective, we'd be pretty happy, but being over 95% effective is just amazing. So we'll see. Okay, well, let's get to your questions here. I have a bunch more other things that came up in the news this week, which is really pretty exciting stuff. So the question here is, are all the new cases from a workplace outbreak? No. We are seeing a bunch of workplaces, but they all tend to be onesie, twosie, threesies. So what's happening at these workplaces, you have 10 people at a workplace. So a dentist's office called me last week. They had an outbreak, and the people who were unvaccinated got the disease. The people who were vaccinated didn't get the disease. So it is happening in workplaces, but typically among those people who are not vaccinated. So the next question is, why are we seeing so many new cases when 50% of the people here are vaccinated? Well, it's because the disease rate among those people who are not vaccinated is so very high. So what we're seeing here, which is really, really different from early on. So early on, what we would see is some mom or dad would get the disease. Frequently, they wouldn't spread it to anybody at home. Sometimes they spread it to one or two people at home. What we're seeing now is everybody gets it at home. Everybody who's not vaccinated gets it at home. So it's remarkable how quickly and how efficiently it spreads, especially the P1. And so we are a little worried about that. Yeah, we think that if we did not have the 50% who were vaccinated, the case rate would be even higher. Now, we've got some of the smartest epidemiologists I've ever worked with here. And some of what happens is most of the people who are vaccinated are older and more cautious people. So many of the people in nursing homes are vaccinated. Many healthcare workers are vaccinated, unvaccinated. But we tend to be people who might get sicker if we got the disease, but we tend not to people who would spread the disease a lot. So how would somebody spread the disease? Go to parties, go to bars, hang out with lots of friends at their house. I think most healthcare workers are more cautious, so they tend not to spread it. The people who do spread this disease a lot, we think are people in their 20s, 30s, and 40s who have very active lives. And with those very active lives, they spread it to lots of people. And those are the groups that we have the lowest rates of vaccine. So how many breakthrough cases have we seen here? One in the last week. Why aren't you reporting them? We report them every week. So we do it on Fridays. We talk about it every Friday on Facebook, and then we publish them on Monday. So over the last month, we've had, I'll have to do the numbers in my head, about 450 cases. And of that, we've had 7 or 8 breakthrough. So it means that 442 cases of 450 are in people who were not vaccinated. 8 of 450 were in people who were vaccinated. That's absolutely remarkable, suggesting a vaccine efficiency of over 90%. So are people that are vaccinated getting sick with COVID from the vaccine? We're not really seeing much of that. We've now checked on a bunch of things, and what we do see is that the fever, achy arm, chills, headaches, vivid dreams do seem to be common, especially with the Moderna and the Pfizer, and especially after the second dose. We've seen a few cases of what's called Moderna arm, where a week or so after you get the Moderna shot, you're getting some redness and sort of an itchy rash where you got it. Not exactly like poison oak, but sort of like poison oak with that. We've seen a few people faint after the J&J vaccine, but people faint after vaccines anyway. And early on, we did a lot of people in nursing homes, and there were some people in the nursing homes who died within the month after they got the vaccine. We had each of those cases reviewed by the state medical examiner. None were thought to be related to the vaccine, all thought to be related to other underlying processes. So they were not counted as either COVID cases or COVID deaths. So when will little guys be able to get vaccinated? So right now, kids 12 and above can be vaccinated with Pfizer. They may bring the ages down lower. I don't know. Below the age of 12, you don't transmit it very much, and you don't get very sick. So the benefit-risk ratio for kids less than 12 is a little different, but I don't know. It's probably not going to be at least until the fall. So if do vaccinations from Cow Creek count towards our goal? If not, how do I get my vaccination counted? Well, we are counting the vaccinations from Cow Creek in our goal because the people in Cow Creek gave us the number of the people who have been vaccinated, and we put that in. And we've worked really hard with the state, so that goes into our number. So when we have our 52% number, that number from Cow Creek is in there. However, that's a clunky way to do it. The very best way would be that the Cow Creek would send their to the feds, and the feds would send immunizations from Douglas County back to Douglas County, and we could figure out the whole number. So that's not happening yet. There are 2 bills in Congress that would mandate that happens, but so far it's not. So the vaccinations from Cow Creek do count towards our goal, but kind of in a backwards way. Now, there's other issues with these vaccines not getting counted. I mean, the other problem is we've had a lot of people lose their vaccine cards. I mean, hard to believe, right? Well, not hard to believe at all. People always lost their vaccine cards. I mean, they're just these little paper cards, and they get stuck someplace, and you bring it with you because you're going somewhere, and then you forget it and whatever. And so it's really is problematic. So for people who got vaccinated and their vaccines are recorded in the state registry, we can give a new card. If you got it at the VA and you lost your card, we can't do it because we don't have the data. Now the VA does have a way to do that, but it would certainly be nice for us to know. Certainly it would be nice for us to know of the people at Cow Creek. So does the clinic have a hard stop tomorrow at 2? We're hoping to get done at 2 tomorrow. We get volunteers from all over the state, and they sign up for a shift, and the shift ends at 2. So we're going to try and get done at 2. Now, if somebody shows up at 2:01, we are not turning anybody away, but please try and get there early so you can get your shave ice, too. That's the other good thing. So when was our largest number of new cases that we've seen here? What was that number, and when was it? Well, let me tell you, I don't know on the top of my head, but I do this graph every day that looks at our highs. So our very highest number was back on February 11th when we had about 44 cases. That week was terrible. We had a big outbreak in the nursing homes, and so we had 37 cases one day and then 41 the next. The peak around that time, the average 7-day average at that time was in the mid-20s. So the first peak, which happened in November, peaked in the mid-20s. The highest day in there was 38. We then had another little peak around January when actually the rest of the state had a much bigger peak. There we had one day of 35. The average in that time was 20. And then back in February, we again had that one day of 44. The peak at that time was in the high 20s. We then had a very fallow period between the beginning of March and really low numbers, about 10 a day, until about the middle of May, and then it went up. When you look at our curve and the state's curve, it looks quite different. I think we're always about a month behind the rest of the state. About a month or so, the state started to see a declining number, so maybe we too will be starting to see this declining number over the next couple of days. But nonetheless, it's really worrisome to me to see this number of cases because we know the variants are here. Now, we look at our variants. Not every case gets tested for variant analysis, but when it does, we look carefully at those. And what we've seen is some of this P1, we've seen some of the B17, some of the 526, which is the one from the East Coast, and it really is a problem. Okay, let's get to more questions. So how many doses are available tomorrow? Lots. We have thousands of doses of both J&J and Pfizer in the community. So, Jeffrey, I challenge anybody to make us run out of doses. I don't think you could, but yeah, it would be, my fondest dream would be tomorrow that we have 3,000 people there, and we have to go get some more doses, but we could do that. I see they're not going to do updates on the weekend, so we're going to report these on Monday for the entire weekend. Yeah, so it's been a month, over a year now, where people put together this report. Now, my entire input on this report is that I review it and say, that looks good. But there's somebody actually has to write this, put all the numbers together, do all the math. And we've got a bunch of people at DPHN who've been working, we haven't taken a day off since last March. And Tamara from the county is doing it. So I think not doing the weekend updates will be fine, but we'll do them on Monday, and we'll do that. So are there certain variants that seem to affect kids most in Douglas County and Klamath County? Yes. So the P1 variant is especially the one that we've seen in kids here in Douglas County. And again, remember the beginning, that's what I said in Brazil, that they're seeing more disease, more hospitalizations, and more deaths among young kids. So it may be that the P1 variant attacks people more equally, not attacks kids preferentially, more than adults, but maybe not so much less than the ancestral strains. So those ancestral strains didn't affect young people very much at all. And as you got older, it was worse and worse and worse and worse and worse. What we see in the variants is they still affect old people, but they affect younger people at a far higher rate than the previous ones did. So that is the big concern. And the big concern is not the variants that we currently know about, because all the variants we currently know about are not that dissimilar. All of them, the vaccine works a little bit. All of them we know are contagious, but not so contagious that public health measures can't control them. The concern is that all the variants build on previous variants. So if you take now the B117, the UK variant, also named Alpha, that's so contagious, and then add some vaccine escape to it, that's going to be really bad. And so that's what we worry most about. So Kurt says, if somebody didn't get the second vaccine on 6 weeks from the first dose, does it need to be restarted? Nope, never needs to be restarted. Actually, there's some data now. There is some data now that 6 to 10 weeks may actually be the optimal time to get the booster. Now, it's a trade-off. You actually get more antibodies if you wait 12 weeks. So you get more antibodies 12 weeks hence, although you have many fewer antibodies from 3 weeks to 12 weeks. So it's sort of a trade-off. But if you got the first dose 6 weeks ago, get the second one tomorrow. We'll be there. So how sick are the kiddos who are getting the P1 variant? They weren't. None got hospitalized, thank goodness, in Douglas County. They were moderately ill, and that's the concern. Because with this disease, there's some people get the disease, fly right through it, just asymptomatic or mildly symptomatic. Some people with moderate symptoms, some people get sicker, and there are some predictive factors. Age, clearly a predictive factor. Underlying conditions, clearly a predictive factor. Viral load, clearly a predictive factor. But there's no way to predict exactly, and so this is a nasty disease. But again, we just have a handful of kids with this P1 variant. They were sick, but not that sick. Okay, so we're going to go through a couple of things here. One is that the state has changed back on the quarantine guidelines. So the quarantine guidelines starting in the very beginning was that everybody needed to quarantine for 14 days. In the fall of last year, what we recognized is that for working people, a 2-week quarantine was really hard stuff. So families who had to do a 2-week quarantine, you couldn't work for those 2 weeks. Many working families are living kind of paycheck to paycheck, and going 2 weeks without a paycheck was hard. Many of them didn't have a fully stocked pantry, and so they were running low on food. And many of the people were living in really cramped quarters, and being inside for 2 weeks in those cramped quarters was really hard. So a bunch of us looked at the data and we said, look, we think you could do it safely by letting people out of quarantine at 7 days if they get tested on the 6th or 7th day. And really, even after the 10th day, even without testing, the risk of disease was low. Well, there were 3 or 4 of us in the state who really worked on this, and the CDC then approved that in December, and the state adopted that in December, where you could do 7 days with a test, 10 days with monitoring, or just a regular 14-day quarantine. In the last time the state had their big peak, and the hospitals were full, they got really worried that there could be some quarantine breakthroughs. So they said everybody needed to go back to 14 days. And we did. But what we've been noticing is that that's been hard for people, and especially been hard this time of the year as seniors were not going to be able to graduate and whatever because they were in quarantine. So this week they changed the guidance back to allowing you the 14-day, the 10-day, or the 7-day. Counties are allowed to choose whichever they do. We choose what works best for people. What works best for you. So if you say, well, I'm a homebody, going to stay home, I'm working online anyway, then the safest and easiest is just do 14-day quarantine at home. On the other hand, if you say, well, geez, I'm working, I really need to get back to my job, and the kids need to go back to school or whatever, then for you, 7 days with a test may be the safest way to do it. So we're doing it. Okay, couple of therapeutic things. So therapeutics is what we would do to treat this, and there have been some very interesting things along the way. So there's a cancer drug called Aplidin, which is used for a rare kind of blood cancer in Australia that actually does seem to have some activity against COVID. This would be good because this drug has already been approved for safety, and we just need to be approved for this new application. The problem is, I heard about this first about 5 months ago, and the report I saw yesterday didn't look like they'd made much progress in 5 months, so that's really concerning. The second one is there's a combination antiviral drug from Japan that looked like it might work. That'll be good. Neither of those are approved drugs, so they could take a while to go. And then there's another antiviral drug called Tempol, Tempol, that seems to be effective, but again, not approved yet. And these antiviral drugs typically take many, many years to come on the market. And so we really are stuck with not very many therapeutics. Really, the only thing that works is steroids. Remdesivir works a little bit. The other thing is these monoclonal antibodies. So you remember the monoclonal antibodies is they found antibodies in people who'd had the disease. They found ones that were most active against the disease. They then grew these antibodies in a laboratory and put them together in a drug. So Eli Lilly has two different monoclonal antibodies. The study came out this week that the first one of these, which is Dannenhoffer, say that twice, was effective, but this was before the variants. It does not seem to be effective against the variants. But when you mix it with a second monoclonal antibody from Lilly, it does seem to be effective. So we'll see how that works. The other one is the Regeneron polyclonal antibody, which used to have to be given IV and was complicated to give, now can be given just as a shot. So that may make it easier to get. Both of those drugs seem to be reasonably good. They seem to decrease the risk of getting hospitalized after you get them. And then this wouldn't be complete unless we talked about hydroxychloroquine and ivermectin. So there's still people who really believe that hydroxychloroquine works. A bunch of the older studies that they've done during the big time, which are now being published. And again, I don't think there's any good data that hydroxychloroquine works. Ivermectin is interesting. So ivermectin is an anti-parasitic drug. We use it in animals. I think my dog has taken it for something. We use it in animals all the time, and we use it in people for conditions like it works for head lice, believe it or not, or scabies. So people are using these drugs, and they're approved in humans, and they seem to work in humans. And there's been hope that ivermectin would help. And there are these little glimmers of hope that it would work. So, for example, there's a study from Mexico City where they gave some people a bag that had ivermectin and compared them to others in the town, and they seemed to do better with fewer hospitalizations. Always hard to know on those kinds of studies. Did richer, more aggressive people who are likely to do better anyway get the drugs or not? But there was certainly a little clue there that it helped. And there are a bunch of other studies that it helps some. However, the places that are really using a lot of ivermectin, which are India and Brazil, are clearly not the poster children in the world here for doing well with COVID. So I do not know what to make of of ivermectin. And what is really annoying to me is I can't do the study to know if ivermectin works or not. I can read the studies, but until people do good, well-controlled, hopefully double-blinded studies, you're not going to know if this stuff works. And that's just the pity of it. There's this drug for obsessive compulsive disorder, which they did a tiny little study last August, almost a year ago, and it was promising, but they've not done the follow-up study. So there's a lot that was wrong with this pandemic, but we'll look back and say one of the things that was really wrong was we did not put enough time, effort, and money into looking at therapeutics. I mean, it's not hard. It's not impossible to do, and on the therapeutics, this is not something where you have to follow somebody for 20 years. Now, if you're going to give me cholesterol-lowering meds and say, is that going to decrease your risk of getting a heart attack over 20 years, you have to take 20 years to do the study. Or if you were going to say, well, if I give you medicine for blood pressure, what's it going to do? That's going to take lots of people and many time. This would not take very many people. I mean, 100 people over 3 weeks, and you could truly know the answers to these things. And the problem with almost all of these studies, ivermectin, I think hydroxychloroquine, almost all of them have come out negative. But with ivermectin, some look positive, some look negative. And how am I, as a reader of the medical literature, to know about this? So it really is concerning. Okay, so another question came in: is it still recommended to get the vaccine if we've already had COVID? So there's been a lot this week about natural immunity from COVID. There was one person who suggested that natural immunity from COVID would be better because it would be more natural and more adaptive. I can't find any data that would back that up. We certainly know that the antibody levels with natural infection are considerably lower than the vaccine. So if you look at antibody levels, if you've not had the disease, they're very low, I would hope. If you have an asymptomatic infection, they're a little higher. If you had a symptomatic infection, it's a little higher. If you've had a vaccine, it's higher still. If you had 2-dose vaccine, it's higher still. And if you had the disease and then had the vaccine, it's the highest. And so you get more protection by getting the vaccine after you get the disease. And so the recommendation still is to get the vaccine if you've already had COVID. You are likely to make lots of antibodies and be very well protected. We've not seen any different side effects from people who got the vaccine after they've had COVID. Now, people say, well, why don't we add those people who've had the disease into the total of people to make herd immunity? And so you could do that. You really could do that. But in Douglas County, that's only 3,000 people. That really doesn't significantly change the numbers when we already have 50,000 people with vaccines. So we would go from 49,000 to 52,000 people who are immune. It's a little change, but it's not the enormous change. It's certainly not the game changer. Really we want to be getting to that 65, 70, 75% of eligible people getting the vaccine. Okay, one of the other things that came out this week was a new naming convention for the variants. And I can tell you, this has been very, very, very confusing because some people have talked about the variants by which mutation they have. So D614G or E484K, and that means that either the 614th or the 484th amino acid has changed. Some people have used what's called the Pango lineage and said it's B1 or P1 or P2 or B617. Some people have used the place where they were first noted, like the B117 first noted in UK. And then other people use other nomenclature. So unless you do this all the time, like I do, it's so confusing. So the World Health Organization is let's end the confusion here. Let's call the original one the ancestral strain. There's no more of it circulating, but we'll call that the ancestral strain. And then we will call the B117, which started in the UK, is the alpha strain. The 351, which started in South Africa as the beta strain. The P1, which started in Brazil as the gamma strain. And 617, which started in India as the delta strain. So you're going to start hearing more of that, the alpha, beta, gamma, and delta strain. So we'll see on that. They're going to probably have other ones too along the time. So my daughter is 11 and a half. We're planning a trip to Guam in July. Is there any chance that a vaccine will be available for her before then? No. They first have to do the study. Then you have to publish the study. The study needs to get reviewed, and that needs to go to the FDA. I think the chance that this would happen before July, since it's already the 4th of June, is pretty unlikely. And so that's hard. So what do you do for people who you can't vaccinate? They're too young, they have reaction to vaccine, they don't want it. What you like to do is create a fortress of immunity around them. Everybody they would come in contact with should be vaccinated. And the more that fortress does not have chinks in the wall, the more likely you are to have to do it. Let me see how things are going in Guam. The Marianas Islands were very low. Let's see where Guam is now. Right, so some places in the world are doing great. And so your chance of getting this disease is going to be related to your how much disease is around, right? So this friend we were talking about who has done missionary work in India, the story is, I don't care if you're vaccinated, still going to India is going to be would be really scary. On the other hand, going to a place in the world where there's not much disease is much safer. So let's see what it looks like on the map here. Oh, to get it over exactly the right spot here for them to know. Yeah, so Guam is considering with the United States at 4.5 cases. Let's go back here to see if I can find the U.S. numbers. So interestingly, Guam and Hawaii have had sometimes where it's been really high and then sometimes where it's been low. Right now, again, most of the U.S. is low. Let's see where Guam is. So the Virgin Islands actually is one of the hottest places in the U.S. at about 15 cases. But then Guam is in the Marianas, I think is what they consider it, less than 1. So very, 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 very little disease there. So good. It sounds like it's be a safe place to go. It's a nice place, but it's really, if you've not been there before, it's really hot. Okay, a couple of other things. Came out this week, a study where they're actually now looking at people who mixed vaccines. That is, they got a Pfizer and then a Moderna or a J&J and then something else. And it looks like they're having pretty good results. Still not enough people to say for sure, but it does not look like they're having unusual reactions, and does not look like they're not getting immunity so good. There's actually some reason to think that it might help to get a different vaccine because it would present a slightly different protein, and this slightly different protein would give you better vaccine protection. Okay, well, there was a thing about the spike protein. So there's this veterinary immunopathologist who's been on the internet, a guy by the name of Dr. Bridle, which is kind of interesting for a veterinarian, but suggesting that it's the spike protein which is really the toxin, and by giving people the mRNA to make the spike protein, it's going to cause all kinds of troubles. Not very convincing to me. First he was just shocked that this vaccine, some of it gets into the bloodstream. Well, any of us who's ever given a shot for anything else knows that it gets in the bloodstream. So when you give a shot for Narcan or a shot for epinephrine or a shot of insulin, you hope it gets in the bloodstream, because it didn't get in the bloodstream, it would take a long time to work. So by getting in the bloodstream quickly, you improve. So if you've ever given somebody Narcan or watched somebody get a shot of Narcan, you put it in, and almost by the time you're done with pushing the needle, the person wakes up, and so it does get into the bloodstream. So he was saying, the spike protein gets in the bloodstream. Well, I don't think any of us didn't think it probably got in the bloodstream. And then his suggestion is that then that spike protein is toxic. Well, the amount of spike protein that you're putting in the vaccine, there's no spike protein in the vaccine itself. There's the mRNA for it. And so your body is making some spike protein, which then your body makes an immune reaction to. But he then extrapolated that this could cause all kinds of troubles, including bleeding problems in everyone, and long-term issues, and heart disease, and brain disease, and ovarian disease. And it's just not particularly believable. There's always stuff that could happen months or years later. But when you look at other vaccines and other things we've done, you really don't see that. So he's really trending on the really trending this week on YouTube. I don't know quite what to make of that. All right, let's see if we have any more questions. So I'm vaccinated, but my friend is not. Is it safe to have lunch outside? Yes. So we think outdoor activities are really quite safe. So the safety of activities is a function of 4 different factors. One, if you're vaccinated or not. So if you're vaccinated, your risk goes down by about 10 or 20-fold. If both of you are vaccinated, it goes down by twice that. If you're outdoors, it goes down by 10-fold. So in this case, it's a vaccinated person, unvaccinated person, outdoors, really pretty safe. And then it's also related to how close you're together. Obviously, if you're right next to each other, more of a risk. How long you're together, and how much disease there is in the community. So there's very little disease in the community. You're both vaccinated, outdoors, seated 3 feet apart for 20 minutes. The risk is infinitesimally low. If you were both not vaccinated in an area where there was a lot of disease, and you were together in a place that had poor ventilation for a long time, your risk would be higher, but still never super high, right? So when we look at any one time, probably only 1 in 300 people have the virus. It's still a lot of people, but only about 1 in 300 people would have the virus, so that even if you did everything wrong, your chance of getting it is still not like 50%, it's 1 or 2%. But since you're doing this on many times, that risk adds up. But having vaccine outside with a friend, probably in the whole scheme of really safe to really unsafe, it's more towards the safe side. Okay, so one of the things I hear a lot is this is an experimental vaccine, not approved. So let me tell you about how things get approved. So in a regular way, what you do is vaccine development is very slow. It typically takes 5 or 10 years for a vaccine to get on the market because it's about economics. So let's say you want to make a new vaccine for rabies, and actually there's a proposal for a new vaccine for rabies made with mRNA technology. They would do phase 1 trial, wait for the results, look at the results. If the results look good, then they would try and raise money for the phase 2 trial. It would take a while to raise the money, then they would do the phase 2, then they would make the vaccine, do the phase 2 trial, get the results. If that looked good, then they do a phase 3 trial. If the phase 3 trial looked good, they would then get the results, submit it to the FDA, which usually takes its good sweet time. And by that time they'd have lots of data because it takes their good sweet time. And 10 years later, they would get approval for their rabies vaccine or a new drug. And so there's been a lot of criticism in the U.S. that drug development is slow. Some of that slowness means that you have more time to follow what happens. These vaccines were developed in a different way. What we recognized was that if we used the traditional strategy for vaccines, it would be years until we had a vaccine. So we did 4 things differently. So the first is we told companies that we will give you money, billions of dollars, to work on a vaccine, and we'll have you work on different kinds of vaccines all at the same time with the hope that one or more will be effective. So in the Warp Speed program was Pfizer, although they didn't take any money, was developing an mRNA vaccine. Moderna, which did take money, developed an mRNA vaccine. Novavax developed a protein vaccine, and J&J developed an adenoviral vector vaccine. So what we did by giving them that money was we got rid of the steps of having to raise money for the next thing. What we told them was, you've got the money. Don't let the money be in the way of you doing this. And with these other vaccines, you'd wait to see if they work to go ahead and make more. I said, look, make the vaccine for the phase 2 and the phase 3, and if it doesn't work, it's only a loss of money. But we can't lose time, and that's what they did. So Warp Speed was actually a brilliant plan. The second thing that they did was they did the phase 1 trials, and as soon as the results from the phase 1 trials were in, they did the phase 2 trial, and then they did the phase 3 trial. After the phase 3 trial, they waited 2 months after that, and then they looked at that data, and then they approved that vaccine in December. That emergency use approval in December was much earlier than you would have ever gotten. It was only based on 2 months of data. FDA doesn't give full approval on anything until you have 6 months of data. But because it was an emergency, there were millions of people sick and lots of people dying. They gave this emergency use authorization. So starting in December. Now, they've had 6 months of data. So both Pfizer and Moderna have had 6 months of data. So again, remember, they started back in October, November with their studies. Now it's May. They have 6 months of data. They've collected the 6 months of data. The 6 months of data is... The 6 months of data looks great. Looks like the vaccines are still very safe and very effective. And both Moderna and Pfizer are going to go for full approval. At that point, it will no longer be an experimental vaccine. It'll be a fully approved vaccine. However, knowing the background stuff, it's a distinction without a difference. And so if you want to wait until it's fully approved, that's great. But again, there's a lot out there about that. Oh, this is experimental, and they didn't really adequately test it. This has been very, very, very adequately tested. Certainly it's been studied in a lot more people than a lot of the drugs that we use. So if you look at the numbers in the trials of some of these other vaccines or the numbers in the trial for other drugs, the number is small, hundreds or thousands. This one was in the tens of thousands, and now it's in the millions and followed out for a long period of time. So Angie says, I had my second Pfizer shot in February and still having some lymph node swelling. So what happens is your body has this really remarkable system called the lymph system, and every part of your body has lymph glands which are responsible for a part of the body. So you have glands under your arm. Usually you can't feel them because they're so small that you can't feel. But the glands under your arms are responsible for your arm and your breast. And so if I get a cut on my arm and it gets infected, the body says, ooh, infection could creep into the rest of the body here. We want to help prevent that. So those tiny little glands that are in my axilla that you can barely see grow to be the size of, say, a grape or a walnut, and they help to stop the infection that gets there. The lymph system also filters out cancer, so that if you had a cancer on your arm, you might get swollen glands here, but more typically, women have cancer in the breast, and it gets caught in the nodes and they get it. So what we do know is that when people get the vaccine, body has a reaction, body says, oh, there's something funny going on there, let me grow those glands to see what's happening. So the question would be whether the glands are in the right area, so that if you got the shot in the arm and the glands are on the other side, not from the shot, or if they're in the neck, not from the shot. But if you got the shot on the left arm and now have glands in the left axilla, it could be from the shot. However, it could be from something else. It could still be from breast cancer or something else. So lymph glands from the shot should last 2 or 3 weeks and then should go away. If you had your second Pfizer in February and you're still having lymph node swelling, you should see somebody about that. PCP might be able to do that. I mean, PCPs know about lymph gland swelling, but really the experts on lymph node swelling are general surgeons, because general surgeons are the ones who take care of the infections that then wind up in the lymph glands, cancers that wind up in the lymph glands, and they're the ones who could do a biopsy of this to tell you whether this gland was important or not. So if it was from the COVID shot, what you'd see is called lymphoid hyperplasia. So it's just basically a lymph gland that's there getting ready to treat the disease. However, if it was swollen because of cancer, it would have cancer cells in it. So you really need to get that checked out. Since February is way too long, I think, to have the lymph node swelling. Now, most times when we say, well, that's way too long for me to say this is benign, it still is benign. But lasting that long, I think you have to be a little bit more nervous. So as a pediatrician, I will tell you swollen glands are like every day. Oh, I felt this little swollen gland on the back of the kid's head. And you really can, because kids have almost no fat on their skull. And so a gland doesn't have to be very big for you to be able to feel it. And if you feel in the diaper area in babies, almost always, crawlers almost always have some glands in their groin, because as they're crawling around, they're banging their legs and scraping their knees and whatever. And then the lymph glands in the groin say, oh, wait a minute, something's happening in the area that I'm responsible for. And so these glands grow up. So when I see a 1-year-old, they almost always have these little pea-sized or BB-sized little glands in the groin. And I usually point them out to the mom and say, well, these are totally normal. Don't worry about them. And you only worry about glands that continue to grow, glands that get big, golf ball size or bigger. So this is important. It could be just from the COVID, from the COVID vaccine, but it could be from something else. So definitely either talk to your PCP or see a surgeon, and they can help you with that. Okay. Well, it's 5 o'clock. If I stay past 5, I turn into a pumpkin. So we'll leave for now. These are great questions. If you have questions, put them in the Facebook questions at douglaspublichealthnetwork.org, and we'll get to them next Tuesday. Again, it's beautiful weather. Please get outside. Remember, being outside is incredibly safe. Still a little bit worried about indoors with poor circulation, but please go and congratulate our seniors who are graduating. They've done such a great job. My daughter-in-law graduated from law school, and although we weren't able to go, we were able to watch it on video, and it was truly, truly wonderful. So congratulations to all the graduates and to their families that really suffered and sacrificed sometimes for them to go to school. Get your shot. Vaccine tomorrow, 9 a.m. to 2 p.m. Come by, get a vaccine. Even if you just want to come by for a shave ice, come by, say hello. We really want to get as many people vaccinated as possible. The vaccine really seems to work. But through all of this, I've been so impressed with the people in Douglas County. So many people have been so kind. People who I sort of haven't seen in years stop and say, oh, thanks for everything you're doing. And it's not just me. I mean, I'm maybe more the Facebook public face of this, but there are 50 people working at DPHN and Aviva and South River on this project, and they're all doing such a great job. So I want to thank them. But as always, I always tell people, be safe and be kind. We'll do this again on Tuesday. Thanks.